Great. Okay.
Okay, I think you're good.
Great.
Okay,
Well,
and you can hear me okay and everything?
can everybody hear?
Yeah.
Awesome. Is that better? Yes, better view. Well, thank you, Leslie. Thank you so much. So, thank you everybody for coming. We're going to get started today. And I thought that we would start with introductions here in the room. I'm Gina Balkus. I'm the CEO at what is now known as the Home Care, Hospice, and Palliative Care Alliance of New Hampshire. For those of you who may not know, we recently merged with the New Hampshire Hospice and Palliative Care Organization. Hi, Kathy. And so we're excited to have our clinical directors together today. And I thought we would start by going around the room. And we'll start right here.
Nancy Dogel from Home Health VNA.
Nancy Dogel from Home Health VNA.
Hi, everyone. I'm Donna Frizzell from the VNA of Manchester and Southern New Hampshire. Nice to see everybody today.
Dawn Moreau, Texas Overtouch and Healthcare. Diane Jadusis with Silver Touch in Merrimack.
Andy Mosier, Central New Hampshire VNA and Hospice.
Deb McCormick from Home Health and Hospice Care. I'm here in our director's place, Lucy's place.
Mary Bendel, Healthy at Home in Nashua.
Barb Hernandez, Franklin VNA and Hospice.
Taylor, Rockingham VNA and Hospice.
Amy Parsons from Bayada Home Health in White River Junction.
Kathy Sorensen, Bayada Home Health in Vermont.
Jen Bellison, Clinical Director at Cornerstone VNA.
Great, thank you so much. So, Al and Amy, I'm not sure if you heard all that, but we have about 15 people in the room, and we're eager to hear about the great work that you're doing in New York State with your Stop Sepsis at Home. So, Al Cardillo is the interim CEO at the Home Care Association of New York State, and with him is his colleague, Amy Bowerman. I'm going to let both of them tell you a little bit about themselves. But the reason that I asked Al and Amy to do this today is New York State, working with their PRO and other national entities, created a really unique sepsis assessment tool to be used in home health. That's really gaining a lot of traction across the country, and thought it would be helpful for to hear about what they're doing. And they have presented at a couple different meetings. So I know that Linda, you saw a presentation at the New England Conference in Maine, but I really wanted Al and Amy to talk with you so that we could decide as a group if this is an initiative that we might want to take on in New Hampshire. So that's really the purpose of today's presentation. So Al and Amy, I'm going to turn it over to you.
Thank you so much, Gina, and thank you for all in attendance. We're eager to have the opportunity to share the work that we've been doing, and we're pretty excited about the extent to which we've progressed across the entire state. You'll see some slides here to this effect, and we're also very, I think we're very inspired to be taking this whole step in the sepsis effort. We know that, certainly across the country, and the data will show as we go through this, the extent to which sepsis is far and away a major coster, mortality, morbidity problem within the system, and of course in the way it touches human life. It's very evident that sepsis has been largely considered a hospital problem, and with a focus on the nature of the hospital experience with it, in terms of cost, treatment, the mortality rate, et cetera. But what we also know is so substantially this is occurring, its onset is in community, and there is a major role that we believe home care can play in this system. We know that across the country, no one has really been talking about home care and sepsis. Invariably, when you bring it up, it only comes up in a hospital context. And we believe that since we've been working on this, we're starting to change the focus in the discussion, and folks are taking notice of the role that home care can play in this. So I thank you for the opportunity for us to talk today, and I especially thank my colleague Amy Bowerman, who's been our clinical leader in this effort, in the entirety of this effort, and who is the executive director of a managed care plan, but as an RN, she is the quality director of a home health agency, and she's part of an entire system of hospital, home care, managed care, and other community services. So as I was saying, we are really inspired in our work on this. And as you can see in this slide, you see lives that have been tremendously affected or lost as a result of sepsis, and the heroic work that the members of the family and other advocates have been doing in this effort have really been an inspiration to us and really carry us in our day. One of the things that we thought we would do is start really by taking a little bit of a segue and setting the table with this video from the National Sepsis Alliance. It's a little lengthy, but it's worth every frame of the video. We in our work are partners with the Sepsis Alliance, with the Stoughton Foundation, and other leaders in this area, and we're very privileged to have access to the resources that they use. And this is a rather compelling table setter, again, in this discussion. So hopefully, with our fingers crossed, this video will play, and then Amy and I will pick it up right after that, and we'll sort of be doing a tag team back and forth on the different components of the slide presentation. Amy, before we run the video, any opening comments that you'd like to make?
No, I think you've covered it nicely, Al. Thank you.
Thanks, Amy. Okay. Now, has the video come up on your screens?
Yeah.
Perfect.
It has.
Okay, here we go. I will say that this evening is going to be a national. It's an annual national meeting called Sepsis Heroes in the city of New York, where there is a convocation basically of physicians, corporate advocates, sepsis survivors, and others in this effort. The individual that you're about to see and her husband were awarded last year with this National Sepsis Award for the work that they've been doing to help prevent and certainly increase sepsis awareness across people, not only nationally but globally. And this is a very, very compelling piece. So here we go.
If a patient feels bad enough that they come into our emergency room, crawl up on a gurney, and put themselves at our mercy because they feel that bad, that we owe it to them to make them prove why they don't have sepsis instead of why they do.
Every year, 258,000 Americans die of a disease that many people have never heard of.
Back in August 2014, I was working at the Choctaw Library. I love people and I love books. And it was after I got home, I started to feel sick. I thought maybe it's the flu. But when I woke up the next morning, I realized I felt a lot worse.
She continued to have fever and chills, a very sore throat. She also was very agitated and couldn't fall asleep.
I had never felt that achy before. And I made the comment to him, I said, I feel like I got run over by a Mack truck. And Jay suggested, you don't get sick. I'm kind of concerned. Let's go to the emergency room and get you checked out.
And when we were seen by the doctor,
he decided that it must be a virus.
The doctor told us it'll probably get worse before it gets better, and he prescribed some cough syrup with codeine.
The symptoms of sepsis mimic quite a few other illnesses, such as the flu. When you come to seek help, frequently the patients are sent away and said, it's a viral illness, or give it 24 hours, or come back in 2 days and if you don't feel better. Unfortunately, with sepsis, it progresses very quickly, and 48 hours is too long to seek treatment.
We came home and I took the medication and I still couldn't sleep. I just kind of laid around all day again. I was in a lot of pain, joint pain, muscle pain. I understand what it means when you feel like you're dying.
It is common that a person who has developed severe sepsis feels perhaps the worst that they have ever felt, like having the flu on steroids.
And then vomiting started. And sometime during the night, I got up because I had diarrhea. So I ended up falling asleep or passing out, I'm not sure what, on the bathroom floor. But once I woke up, then I couldn't even muster up the strength to raise my voice and to holler for him. We needed to go back to the emergency room.
If you're at home and you think your loved one has an infection and that they might have sepsis, it's important that you dial 911 and you tell the operator, I think they have sepsis and I need to get them to the emergency room. Sepsis is an emergency, plain and simple.
It was a 32-hour time difference from the first time I was at the emergency room to the second time I went to the emergency room.
Every hour sepsis goes untreated, the mortality rate climbs.
As soon as they started taking my vitals, they realized something was really wrong. My heart rate was up. I started to get shooting pains in my arms. It was absolutely the worst pain I'd ever been in.
She wasn't producing any urine.
They thought it could possibly be a urinary tract infection, could be causing the high heart rate and the low blood pressure. And they started giving me fluids, and they started me on a broad spectrum antibiotic.
Antibiotics must be given as soon as we can humanly give them when we suspect sepsis. Hesitating leads to death in many cases. But you need to get the results of your blood cultures so that you can narrow those antibiotics as soon as possible.
So the doctor said that they would need to take her to the ICU.
That's where it starts to get a blur. I mean, everything was happening so quick, and so they were really concerned because my kidneys weren't functioning.
The doctor came in and just told us that, obviously she was sick, she was septic.
And they started to explain about sepsis and septic shock. That's the first we heard anything about it.
Nearly half of Americans have never heard the word sepsis.
Many people have never heard of sepsis because, frankly, their doctors never use the term. Even on the death certificate, it most frequently does not say sepsis. Sepsis is the way that infections kill, and no one knows.
There are nearly 1.6 million cases of sepsis each year. And of these cases, 20% of them die. Sepsis is the body's overwhelming and potentially life-threatening response to an infection, which can lead to tissue damage, organ failure, and death.
I think it's reasonably common that people who hear that their loved one is septic do become worried that they could get sepsis themselves.
Sepsis is not contagious. It's your individual response to an infection. There are different stages to sepsis, and there's SIRS, sepsis, severe sepsis, and then ultimately septic shock. SIRS is a systemic inflammatory response syndrome. SIRS is a normal immune response. It's what would be expected when you have an infection or bacteria or virus enter your body. If SIRS progresses and your body is unable to fight that bacteria or virus or infection off on its own, it'll develop into sepsis. That's the next stage. Some of the symptoms are problems breathing, fast heart rate, high temperature or chills, extreme pain. Some people refer to it as the worst pain they've ever felt. Pale or discolored skin, dizzy or lightheaded, difficult to rouse or confused. When you have a combination of some of these symptoms, and not just one single, that is sepsis, and that's the next stage. When you have sepsis, and you have one or more organs that are not functioning properly, that equals severe sepsis. When you have severe sepsis and you have low blood pressure that's not responding to IV fluids, now you have septic shock.
In the beginning, it's difficult to diagnose but easy to treat. But in the course of time, it becomes easy to recognize but difficult to treat. Severe sepsis is the #1 killer of people in hospitals in the United States.
Most people believe that infections that lead to sepsis were acquired in the hospital. But in fact, 80% of the infections that lead to sepsis are acquired in the community. So there are different types of infections that can lead to sepsis. They're parasitic, bacterial, fungal, or viral. It can happen from any type of infection. It could be C. diff, pneumonia, urinary tract infections, MRSA. It could be as common as an ear infection or a strep throat or, just a cut Everyday things can trigger sepsis. It's very random. It's something that can happen to anybody at any time. Unfortunately, there is no single definitive test for sepsis, but there are some commonly used tests that may indicate sepsis. They include lactic acid tests, which indicate that your body is attempting to function without oxygen. Blood cultures can indicate that there's an infection and what kind of infection it is. Procalcitonin or PCT tests measure PCT hormone levels. Elevated levels of PCT may indicate a bacterial infection along with an extreme overreaction of the immune system. Those most vulnerable to sepsis are the very young, the very old, and those with chronic conditions. There are some chronic diseases that make people more vulnerable to developing sepsis. The most common are COPD and diabetes, but there are others such as multiple sclerosis, HIV, cirrhosis, and cancer.
When I started researching sepsis, septic shock, and all the things associated with it, and it came to my realization that my wife was in an all-out war on sepsis. She was fighting for her life, but no one mentioned the fact that there was a very good chance my wife would be passing in the next 24 to 48 hours or anything like that. I never realized then that she was probably not going to make it.
Sepsis kills a person every 2 minutes in the United States.
Sometime that night, things got really worse, and I needed to be put on a ventilator.
Her lungs were failing, her blood pressure was dropping, they were putting her on vasopressors, her limbs, hands and feet were turning a gray, bluish gray, which is the first signs of tissue death.
In septic shock cases, we have to give vasopressor agents, which are drugs that constrict the blood vessels just to keep the blood pressure up, but that constriction also results in reduced blood flow to organs and tissues that need oxygen in order to survive. So the combination of capillary clotting and vasopressor often results in death of fingers, toes, tips of noses, ears, so that those need to be amputated in order for the patient to survive.
It's almost surreal at times because, again, she's not like a cancer patient that had months or even years. We had minutes and hours, and she deteriorated so rapidly, and that's what people need to understand, is how quickly you can go from healthy to on your deathbed.
In our hospital, the same way that you'll hear on the PA system code blue for someone whose heart has stopped, you'll also hear
Code sepsis ICU. Code sepsis ICU.
Getting the blood cultures drawn and antibiotics into patients within an hour is not common, but we found it to be extremely effective in helping our patients, and we've reduced our mortality rates from sepsis by 50%. Every hospital should have a code sepsis team. It's a way to have like a blueprint of how we're going to treat septic patients.
The septic shock was so bad that they gave me a 5% chance of surviving.
If sepsis was treated as a medical emergency, many more patients could be saved. Upwards of 200,000 patients per year here in the U.S.
When the doctor came in on Tuesday, August 12th, he said, "It's time for you and your family to prepare and say final goodbyes." At the end of the conversation, I had said, "If you don't feel like you can fight anymore, you just need to let me know." She immediately opened her eyes up and gave me the dirtiest look that I've ever seen. And I knew right then that we were still in the fight. Over the next 7 to 10 days, her condition would gradually improve. And after about 10 days, we realized that she was going to make it, but the repercussions were going to be catastrophic. Her limbs were literally dying in front of my eyes, and there's nothing that I or anybody could do about it.
At that point, I understood and I knew that they were going to need to be amputated. I more or less just wanted to get it over with. I was tired of looking at them. They were useless, and I was very sensitive about other people seeing them, so I tried to keep them hidden so people wouldn't see them.
On average, over 30 people a day undergo a sepsis-associated amputation in the United States.
As a husband and a protector, there's probably no worse feeling than watching your wife suffer and there's nothing that you can do, and knowing that after she fought so hard to beat this illness when she was given very little chance, she's now going to have to spend the rest of her life as a quadruple amputee. So yes, it was very devastating.
There's depression, there is fear, anxiety. These are all things that some sepsis survivors are reporting to have following their first episode. Some patients even suffer from post-traumatic stress disorder.
I was in rehab, and I looked at him and I told him, I said, I don't expect you to stay with me. I said, this is not what you signed up for. I said, I feel like this has ruined my life, and the only thing worse than this is ruining 2 lives. This was my problem. This happened to me. And he was like, no, this happened to us. It's us. He's like, I'm not going anywhere. So that was a huge burden off of me. He's really been my rock.
Life after sepsis can be tough for anyone who gets it. A substantial number are left with permanent impairment.
But just the way she's handled the whole situation and been willing to help other people, mentor other amputees, and get involved in raising awareness of sepsis. It's important to me that people understand sepsis. I don't want my wife to have lost her hands and feet in vain.
You need to know the symptoms and know what to do right away. It can spread so quickly.
You've got to advocate for your care and for the care of your loved ones, because that can make all the difference.
Excellent sepsis care is absolutely achievable in the tiniest of hospitals in the most rural and isolated of locations. Because, as we say, the mainstays of treatment are early antibiotics and fluids, they nip the sepsis in the bud. They're able to keep people at home.
Some doctors are reluctant to initiate antibiotics because of this possibility of resistance. In the case of sepsis, unfortunately, that's dangerous. There is no alternative. If you have a septic patient, that patient has to have antibiotics being administered to them.
If I had had, a blood test and they could have given me some antibiotics, then this would not have happened. And this could have been prevented.
Another way to avoid the dangers of sepsis is to prevent infections from taking hold in the first place. This can be accomplished by making sure to keep up to date on all your vaccinations. Make sure to clean and treat any open wounds. Complete all prescribed courses of antibiotics. And practice good hygiene, including thorough hand washing.
All great medicine is a partnership between patients and their physician. If we can get doctors and nurses and lay people themselves educated about how to recognize sepsis and how to treat it early and aggressively, we'll have a tremendously positive impact on the outcomes from sepsis.
There is hope. Through education for the general public and for healthcare providers, we can certainly improve outcomes and save lives.
1 1,000, 2 1,000, 3 1,000. 3 seconds. Every 3 seconds, someone in the world dies of sepsis. But in the 9.58 seconds it takes Usain Bolt to run 100 meters, 3 people in the world have died of sepsis. I don't know about you, but that's ridiculous to me.
All right, thank you for helping overcome the technical difficulty and for showing that video, which I think really brings to life the point that I was alluding to before about, kind of what is inspiring our work, and certainly what we believe underscores bringing everybody into the process to try to address this problem. So moving to this next slide, this just gives you a kind of introduces you to the topic and just gives you like an initial glimpse of the tool that we created and what we will be talking about throughout this presentation. As Gina had said earlier, we've been working with core partners in this process. Our QIO, which is IPRO, Sepsis Alliance, the Rory Staunton Foundation, and of course, particular acknowledgement to Amy, who is on the phone with us, who has led our work group effort throughout. Also, as we were launching this effort, we were awarded a major grant by the New York State Health Foundation to support statewide training that we have done. So we've brought providers together in every region of the state, home care agencies, along with partners, hospitals, EMS, health plans, other partners, physicians, to introduce this tool and conduct some pretty extensive walkthroughs of the tool itself and guidance for agency adoption of the tool. So again, our appreciation to the foundation to have supported the effort to this extent.
Hey, Al?
Yes.
Can I interrupt? This is Gina. Can you put your PowerPoint on slideshow so we have full screen view?
Yep. So I'm sorry. Yes, I will. There you go.
Awesome. Thank you.
So that's just a bit more in background on Amy and myself. So during the presentation today, we'll be presenting the screening tools that you just saw on the prior screen. We'll be describing a training toolkit that we've also assembled. We'll be reviewing other sepsis informational materials and partner resources, talking about our data collection effort that we make a part of this tool, but also that our QIO has considerably assisted us with. And we'll talk about our initial implementation experiences and next steps. We really very strongly believe that it's really a collaboration of the continuum partner, which is really essential in providing an effective response in the whole sepsis effort. So in our presentation today, we'll talk about sepsis as a medical emergency. Somewhat along the lines of what you just heard in the video, but also really be presenting and emphasizing some very critical facts that are very relevant to why sepsis is critical in home care and why home care's role in sepsis can be very, very important. We'll give you some background on how we developed this tool. Amy will give a very in-depth walkthrough of the tool. We'll also cover some case examples so that you can see how it actually works within cases, and again, talk more about our data collection effort, collaboration with partners, and our next steps. So Amy, I don't know if you want to take it for the next few slides in terms of background on sepsis right through the sepsis facts.
Sure. Are you going to keep the ball with moving the slides forward?
Yep, I will. And I'll pause.
Okay,
I'll pause at different parts to see if you want to do that part or you'd like me to.
Okay, great. So can everybody hear me okay? Because I was having a little bit of technical difficulty myself.
Oh, no,
we can hear you just fine.
Okay, great. Sepsis. So let's start with sepsis, which many people are not very familiar with, is the body's overwhelming and life-threatening response to infection. It can lead to the tissue damage, organ failure, and ultimately death. Sepsis happens very quickly and can be confused with other conditions. Sepsis is a medical emergency. Sepsis is deadly, and when it's not recognized quickly and treated, the mortality is very high. Time is of the essence for recognition and treatment of sepsis in order to save lives, and healthcare providers are the critical link to preventing and recognizing the treatment of sepsis. Next slide. Sepsis affects the healthy, the ill, the strong, the weak, the young, the old, all of us, all from young to old chronically ill, immunocompromised, any of everybody. As you can see, some of the faces that have been affected by sepsis, and who better that sees these people than home care. Next slide. Common infections that lead to sepsis are respiratory infections, such as pneumonia, urinary tract infections, any of the abdominal infections, and then any type of skin infection or wound as well.
Amy, would you like me to do these slides, or do you want to do these slides, these next set?
No, you can go ahead.
Okay. So this first slide is really in the big picture, and it really attempts to also show the strong relevance of home care. 80 to 90% of sepsis-related infections occur in home and community, and that statistic is often a surprise to clinicians, whether they are working in hospital, working in home care, managed care, et cetera. It's because sepsis is so often thought of as a hospital problem, but you see the onset is substantially occurring in community. The high-risk populations are in home care or within typical reach of home care and primary and community partners, and you'll see that as we outline the high-risk categories as we move into this. Early recognition and time to treatment is critical. Maximizing prevention and awareness, pre-hospital and community intervention and partner synchronization is really very critical. Home care, also post-sepsis transition and care are also very critical. As you'll see as we go through this, the recurrence and the readmission risks are very high, as is the need often for complex and interdisciplinary follow-up care for sepsis. There is, a well-documented post-sepsis syndrome in which there are implications for cognition and, of course, other physiological function for individuals who survive sepsis, as well as in affect in literally every area of their lives. These cases are very prime for collaborative follow-up by hospitals, physicians, home care, and other partners. So some of the statistics, which are pretty staggering. There's 1.7 million cases of sepsis each year in the United States. Over 250,000 deaths each year. Every 2 minutes, somebody in the U.S. dies of sepsis. Sepsis takes more children than cancer, 18 children a day. The cost of sepsis is the number one cost of hospitalization at $27 billion per year. Every 20 seconds, someone is hospitalized with sepsis. It's the number one cause of death in U.S. hospitals. It's the number one driver of readmissions to hospitals, and really by far. This chart here shows really and this chart is already a few years old, but it shows the difference in the aggregate all-payer costs for hospitals in millions compared to what is the very next cost factor in line. If you look at the difference between septicemia and osteoarthritis, it's basically a 50% difference in the total cost for osteoarthritis than compared upward to sepsis. So it's very, very substantial in terms of in the position that sepsis holds in the cost profile and hospitalization profile across the country. Sepsis is the number one Medicaid expense for potentially avoidable hospitalizations for the general population in New York State, and that just excludes schizophrenia in the mental health population. And it's number two nationally as a Medicaid hospital expense after live newborns. 1 in 4 hospital patients treated for sepsis are readmitted in the first 30 days, and that number jumps up to 30% in 60 or 90 days. Sepsis is nearly double the readmission rate of the top CMS clocked readmission causes. So the next one, let's say, for example, is heart failure. So sepsis is nearly double the readmission rate of the next closest on those lists. And you can see the other conditions and how it outpaces those other conditions. Up to 50% of sepsis survivors suffer from post-sepsis syndrome with consequences for ongoing primary and community care. Interestingly and sadly, one of the nurses who actually has been leading her agency's effort in implementing our home care tool actually developed sepsis in the middle of the work that she's been doing, and she also has post-sepsis syndrome. She's actually going to be a speaker at a conference that we're holding in a few weeks to talk about how this has gripped her personally as well as professionally. The Department of Health and Human Services estimates that sepsis results in an average of 38 amputations a day, and it was certainly very graphic in the video that we just saw. And again, commonly misunderstood as a hospital problem, 80 to 90% of sepsis cases originate in home and community. And these other items are ones I covered in the bigger picture. So, I mean, the fact pattern certainly sets up a very, I think, not only a very alarming picture in terms of sepsis and sepsis as a medical emergency, but I think it's very clear the kind of role that home care can play given the population that we encounter and, certainly given the magnitude of the problem. So among the highest risks are the elderly, the chronically ill, persons with disabilities, the very young, especially medically fragile children, individuals with compromised immune systems, individuals with recurrent UTI and pneumonia, and others that are routinely within home care's scope and reach, like post-surgical patients, maternal and neonatal care. So it's pretty clear that these high risk, see if I can move this down. Okay, clearly these high risk groups are the home care population, and home care treats those that are really most vulnerable to sepsis. In screening for sepsis, the tool that we created also simultaneously screens for other criteria that are associated with other high risks for avoidable hospitalizations, and they're on the list below. The 6 categories that you see there are the top categories that New York State has identified as the top conditions for avoidable avoidable hospitalizations, not just Medicaid, but avoidable hospitalizations in our state. And the tool, and you'll note as Amy gives you the review of the tool later, screens either directly or indirectly for criteria associated with those conditions. So we believe that the use of this tool also offers a major opportunity for quality and intervention in across these high risk areas, not just limited to sepsis. The tool also syncs and the ability to target those high risk populations also syncs with some of the key reform goals in the models that both the federal government and state governments are emphasizing within the system, whether they're value-based payment, managed care, other accountable or integrated models. We're a DSRIP state in New York, so it's a key criterion there. But even if your state is not a DSRIP state, it's clear that these are major goals and milestones within those other models. ER avoidance, readmission avoidance, improvement in population health. So we view those as benefits to the tool. But also very broadly, nurses that are utilizing this tool attest to the overall intensified focus that it gives to them, the aides, and the patients on overall infection risk and infection control, and that further intensified focus itself is well serving of the quality and management and prevention within the population. Some additional reasons for engaging home health specifically in sepsis. Well, first of all, let's look at some of home care's very unique position and credentials. Home care clinicians are in homes and communities, the places where 80 to 90% of this occurs, and also the place where dealing with the populations at highest risk. Home care clinicians are expert educators, screeners, evaluators, interveners, and system navigators. So we are the core competencies, particularly of home care nurses, but also physical therapists and other clinicians in care, are just critical given the fact that the sepsis requires a very highly timed and very well organized and synchronized type of response between the patient, EMS, the physician, the ER, home care is excellent at that, as well as the kind of patient, family, and community education that can really make a difference in this effort. Sepsis is also one of those conditions that's associated with significant disparities in healthcare. As we know, certain populations are often, exhibiting access problems or higher prevalence of certain conditions because of a variety of aspects, sometimes geographic, other times cultural, in nature. Home care is generally in a good position in the way it operates, where we are matching the cultural needs and cultural and communication and linguistic needs of patients with those who care for them. And so home care is well positioned, we think, to also assist in this condition, because it provides those bridges into communication in alignment with patients. And home care is also the growing and future milieu of care. If more and more emphasis is going to be on care in the community and particularly avoidance of hospitalizations and substitution for nursing homes, home care really has to be an important player in the whole sepsis intervention effort. So for all of those reasons and really more, we feel that home care is really very, very importantly positioned to be a partner in this process. And I think all the more opportunity, given the fact that nowhere else in the country, has this really been in the forefront. It's something that really sort of its day and time have well come. So I'll give you a little background on the development of this of the tool and the initiative that we have. So starting about 4 or 5 years ago, we undertook some very deliberate efforts to see how home care could collaborate in prevention and intervention. And we weren't really sure where this was going to go, whether it was going to be informational, whether it was really going to be in the communication aspect between home care staff and physicians. We weren't quite sure. So the first thing we did was we called around the country and we looked at every credible and really frontline source that was working in sepsis to see what they were doing with home care, what they knew of anything that existed for home care, and honestly, it was a blank slate. No models, no activity, no guidance. But every place we called, there was a lot of interest in what we might eventually find. So what we did was we engaged clinical experts at the state and national level to drill down further. We had a presentation at our quality forum that we had by Dr. Martin Dorfler, who's the clinical director at Northwell Health System on Long Island, who had been really doing some tremendous work in sepsis and achieved reduction in mortality. And Dr. Dorfler talked about timing being very important and really early recognition and intervention. But when we asked him on the dais what his system was doing in the area of home care, he said, well, we really haven't gotten there yet. Hospitals have been looking at this as a critical care issue. We've moved really to focus on the ER and intervention. But if you do something, we promise we'll work with you and support you. So at that forum was also Amy Bowerman, and we put our heads together and decided that we would go forward and see what further we could learn and whether we could develop this as an active initiative within the Home Care Association. So we developed a work group around this issue, and Dr. Simpson, who you saw on the video, was part of our work group, as was Dr. Dorfler. And Dr. Simpson, presented to our quality committee and to our board on why he, first of all, on all the background on sepsis, but why he felt that this was a very worthy undertaking. Again, remember that, you all know as home care and hospice agencies what affects your everyday, we're all we're struggling just to make payroll, struggling to have a viable presence in the community. And while sepsis obviously is something important, it's not too much on the priority radar when we think of, well, what am I going to do today in my agency? What do I need to do to meet the needs of the community? So in this discussion, what was really reinforced was the Home Care Association should definitely take this on, and you should see how you bring this into a basic standard of care for your patients. And that led to, again, the development of a work group, the drafting of a tool, a corresponding algorithm and protocol, which you see the algorithm on this page, also an education tool. Amy will be walking you through that. But we did some substantial vetting of the tool. We refined the tool, and again, we brought in specialists of I think great people who are in significant positions to provide input and help us refine where we were going. And the beta test confirmed that we were on the right track. It was user friendly. It was very statistically reliable. That people were completing the tool the same way and pretty much coming to the same conclusions, which we found and has been reinforced ever since the tool has been in use. So again, what has evolved from this is really the first of a kind, a standard tool that we've applied across our state that is being widely recognized and supported in our state and by various players across the nation, including CDC and others. The core components are the screening tool, the algorithm, protocol, and an education zone tool. The tool was designed to specifically sync with sepsis criteria that are used in our hospitals and with the New York State sepsis protocol requirements. So in our state, right around the time we were exploring this, hospitals were being mandated by our state to put in place protocols for screening and intervention with respect to sepsis. And those protocols were named after Rory Staunton. They're called Rory's regulations. And if you don't know the Staunton case, Rory Staunton was a 12-year-old boy who scratched his arm playing basketball in gym and several days later died from sepsis. And in that intervening period was back and forth to hospital and back and forth to primary care professionals, none of whom accurately diagnosed his condition until it was far too late. His parents created a foundation, the Rory Staunton Foundation for Sepsis Prevention, and that has really been a very powerful model and inspiring source within New York. All along the way, and really from the beginning in this effort, we were partnering with our QIO. Sarah Butterfield is our Senior Director for Quality at our QIO, and Eve Bankert was someone who was brought in by Sarah and by IPRO to actually run their sepsis. They have a whole sepsis program, which I'll allude to in a moment. But they were part of our effort really from the very beginning and continue to be very critical partners in what we're doing. And through the work that they did, the education zone tool, which you saw earlier and which Amy will give you a better presentation of, was made part of this effort. So the tool is specifically designed for use by home care clinicians, but it is also applicable to and being sought for use in broader settings, including in systemic models that hospitals and ambulatory care, ACOs, are putting in place. Within ambulatory care, even nursing homes have expressed interest in adopting the tool of developmental disabilities providers and others. So our goal in New York with this is statewide adoption of this tool. And by all home care agencies and any other applicable setting. I talked to you a bit about the training that we've been doing, but the way we make this tool available is that we require, first we have a user agreement with any provider, and the user agreement is really to ensure that there's quality and standardization in how that provider is going to use the tool, as well as preparation. So we require those as prerequisites by the agencies before they just basically take and start using this tool. We formally launched this tool at the end of March 2017, and that was following 5 to 6 months of preparatory education with the providers. We provided a written notice to our Commission of Health and our health department because this was an industry, originated and to be applied tool, and we wanted to be sure that in both surveillance and in credentialing and in all other respects, our health department was on board, and they have been a very strong partner of what we're doing. Providers in New York State have been using the tool. The experience has been substantially positive. The biggest challenge area that we'll talk about has to do with integration into EHRs. But again, we'll talk about that and how that is progressing. And I mentioned to you the grant that we created. As of June 1st, 55 of our 62 counties have at least one home care agency that is has been trained and authorized to be using this tool. And there's a map of New York. And I want to say with a great deal of pride as our current association executive that a year and a half ago, that was white except for pilot sites. So if you think about the daily challenges that you're all under, and to think about actually incorporating a mandate, but a self-imposed mandate, and to have committed to doing that, I think that speaks incredibly well of the home care community. And especially as the hospitals continue to struggle with the fact that the state mandated a sepsis tool on them, one of the real differences, we created something that is already oriented to home care, developed from the grassroots up, and the entire roadmap, if you will, of the tool and the guidelines and everything are hand ready for any agency that wants to go forward. And I think that really made a difference in this effort. So there's been some interesting early findings. And I'll just be working from findings of one of the agencies and talk about this a bit later. But in our findings, one agency reported over 100 cases in their load that met sepsis criteria where that patient was treated in the home with the PCP and the home care agency. If you think about the cost factor, those 100 cases, when you consider the average cost of a septicemia admission in a hospital, and that's just the average, the savings are in the millions from just those 100 cases. If those cases were intervened before the patient went into septic shock, the savings are well beyond this, not to mention the life savings. That same agency identified over 100 cases that met the criteria for severe sepsis, and care was arranged in the ED. When you look at the national statistics, the average expenditure of a sepsis case caught early and treated in the ED is multiple times less expensive than if that patient progresses and goes into critical care. And again, not to mention the fact that one is hoping to prevent the kind of morbidity that you saw in the person in the video. The other thing is that I mentioned earlier, but I've done a series of focused meetings with providers this summer, very intensive meetings, and everybody talked about the improvement in general awareness of infection. But the other thing that they talked about was the fact that aides that have been trained utilizing not the sepsis tool, but this education zone tool, has made the aides a lot more aware of not only conditions related to sepsis, but other conditions which are associated with a decline in health or certainly a potential emergency that could be avoided. And they've really noted the increase in the reports between the aides and the agency on changes in patient care. I mentioned this, the data effort. So iPro has created a HIPAA-compliant, or is utilizing a HIPAA-compliant data collection portal through the REDCap methodology. That's REDCap, that will enable providers to upload data from this sepsis tool and then be available back to the provider that will have measures of all of the criteria that are either assessed or actions that are taken under the screening tool. So when Amy goes through the tool and goes through the questions and the potential areas that would be noted and charted based on the tool, all that information is able to be uploaded into this system and available to the agency for important information on their general patient profile for these conditions. Of course, clear information on sepsis, but also very valuable population health data. The portal will also enable the agency to determine whether or not the tool is being completed accurately, and whether there's any other items of either interest or concern based on the data. We will have access, and the QIO will have access to de-identified data. And from that, just like as I was attributing before on the 100 cases where hospitalizations were avoided, able to utilize that data to further support provider efforts, provider education, and policy development. this will also be a first of its kind data set in the country on sepsis in the community. We also have developed this Stop Sepsis at Home website. And on this site, we have links to most of our training education resources, as well as to our resource partners, which is, again, it's a very important focal point for not only just initial information and awareness among the agencies, but for ongoing capabilities for, in-service training and education. We also put together, to guide this effort, a steering committee. And if you look at who's on this committee, and I think, and I'm going to talk about the advantages of this from multiple perspectives, you can see that on this is not only our association and our QIO, our other partners, Sepsis Alliance, the Staunton Foundation, but the CDC, our Department of Health, Office for Aging, state medical societies, state and regional hospital associations, payer associations, our two major EMS associations, consumers. Again, it goes on and on. Having that kind of group that supports what you're doing and links in also serves the purpose of them educating the other sectors about what home care is doing, helping with the other links. But I think it also really serves as a great basis for home care collaborating on other similar kinds of conditions where I think we can also make a contribution and where we also can sort of get a head start in our partner development. I think it also speaks well of the home care industry. It's a little bit like the tail wagging the dog on something this serious. So I would say these individuals have all been very, very willing and enthusiastic partners of ours in this effort. I want to speak just quickly to this. So while after we created the tool and before it was launched and we were still beta testing it, our QIO applied for and received a grant from CMS to do two regional sepsis community education and early identification efforts. And those are located in central New York and in the western New York region. Through that, they trained over 10,000 clinicians in these regions using our tool and using other training aids, which would be available to you through the toolkit that we have. And I just take a moment to say everything that we have that can be of help to you in implementation is yours to work with. We're happy to share that. The project runs through 2018, and we have benefited from the experience of that project as it has informed the work that we've done. One of the things that this next slide shows is the extent to which individuals in home care, so this is before implementation of our tool, shows you the extent of admissions, septicemia admissions, who have been receiving home care or had received home care, and the numbers are really pretty high. So it really shows an opportunity there in the statistical base for home care's implementation. In terms of the training, what this basically shows is the level of reported increase in knowledge from individuals that have received training. In the training that we did, I would say 85 to 95% of the clinicians who attended reported that they had gained substantially in the working knowledge that they had about sepsis that they did not know before they attended our training. And the way a number of the nurses have talked about it, and I think what Amy will talk about too in terms of the tool, is it's not like a nurse doesn't know the signs and symptoms, or may not be aware of prevalence, but it's sort of putting it all together in a focal point is what really makes such a substantial difference. This is just a few slides on our partners. And again, we would really encourage you, whether you work forward with our tool or your own way, make good contact with the Sepsis Alliance and with the Rory Staunton Foundation. They provide endless resources right from their website that are very, very useful, like the video that you just saw. Sepsis Alliance just recently did a video for EMS. They've done a training video on surviving sepsis and on post-sepsis needs. So a lot of good stuff. There's an actual video that's for nurses specifically, so it's obviously advanced in its clinical presentation, and I would commend all those to your attention. So now I'm going to turn this long-awaited baton over to Amy, who will walk you through the sepsis tool and go through the cases and answer the questions that you have. So, Amy?
Okay. I'd like to give you a little bit of history with, as Alice touched upon some of the regulations that we have here in New York State. But back in 2013 is when New York State's Department of Health mandated the acute care facilities to implement policy and protocols to easily identify and rapidly treat patients that were identified to be risk for sepsis. Obviously, the goal was to improve patient outcomes and decrease the mortality, and that early recognition is really what makes that early recognition and that treatment is really what makes those differences. So in 2014 is when Al and I happened to meet back up. So I transitioned back from the acute side back into home care, and that's when I said, well, what are we doing about sepsis? And many of my fellow colleagues looked at me and said to me, Amy, sepsis only happens in the hospital. You have to get back into home care mindset. And I said, we'll see about that. So, needless to say, so we started to develop the sepsis screening tool. The sepsis screening tool assists and streamlines a clinician's assessment to recognize the clinical signs and symptoms of sepsis in the post-acute setting, such as home care. It is based on the same guidelines that are used in the acute care facilities in New York State. It's also based on something that is national called QSOFA criteria. So it's very evidence-based criteria. The sepsis screen tool crosswalks the same information that an emergency department would utilize the same screening in a triage. So the information is easily recognizable to report off to an emergency department so that they can expedite a patient's care for rapid treatment, which obviously it's much better to have that ability to be able to let an emergency department know that you've identified this patient as potential sepsis versus having them sit in a waiting room. The screening tool is a sequence of 3 questions. The questions are answered based on the clinician's assessment. It does not require any type of special assessment. It is any routine head-to-toe assessment. You can meet and answer these questions. The answers are based on the clinical findings of the assessment, and once all the questions have been answered, the screening tool provides the clinician the guidance for follow-up and interventions, keeping in mind that the screening tool is not a diagnostic tool. It is a screening tool. Okay? Next slide, Al. Oops, there we go. So these are the 3 questions that really drive the screening tool. And the first question is, does the patient's history, physical examination, or other findings suggest an infection or potential source of infection? The clinician would answer that question, yes or no, based on their head-to-toe assessment. Some of the obvious source sites of those of the possibilities of answering yes are pneumonia, urinary tract infections, wound infections. We try to give some of the possibilities. However, this list is not all-inclusive of everything that could potentially be a yes. So that's why we left the other areas so somebody can document in any other different things. It also helps with these as suggestions to have clinicians start to think about some of the things that they are looking at. A lot of people forget that, like implantable devices, like pain devices or a portacath, those are all source sites of infection. Question 2, are any 2 or more of the following systemic criteria present? So does the patient have a fever, or are they hypothermic? Are they tachycardic? or are they tachypnic? That is all based on the clinical assessment. And then question 3 is there at least one new onset? And that's very, very important to this question. It has to be a new onset of sepsis-related organ dysfunction criteria present from the list. So just to give you an example, if a patient, we're under the lung, if you have a patient who is a COPD who lives at a baseline of 89% for their oximetry, that is not a new onset, even though it's below the baseline for this. So you would want to make sure if they were at 80 for the day and their baseline was 89, then that's a new onset. But that new onset is very, very important. Good. Next slide. Once all of those questions are completed, we move to the follow-up. And the follow-up for the clinicians gives them, it absolutely gives them the direction that they need. So if the answer to question 1 is yes, but the answer to 2 and 3 are no, then the patient are educated on the signs and symptoms of sepsis, and we provide them the information of the early signs and symptoms of sepsis, which is the zone tool, which I will go over shortly. And the same, and it goes through each algorithm, but it gives them clear direction and follow-up as to what needs to happen in the event of what questions are answered and how they're answered. Now, as you can see, under the patient meets criteria for sepsis, you can see at the end that there is obtain MD order to draw CBC. That is not required. Some agencies do not draw bloods. So if your agency does, then you can certainly ask the provider if they would like blood work done. If your agency does not, then obviously you would not make that offer for them. And then the patient meets criteria for severe sepsis is an answer to yes to 1, 2, and 3. And the patient meeting that severe sepsis, you absolutely need to educate the patient and the caregiver if present as to why they are meeting severe sepsis criteria. We need to notify the provider. You need to have the patient transported to the emergency department for an evaluation. And those are the follow-up pieces. And then next slide. Interventions. These interventions are some of the interventions that we had run into and occurred during our beta testing that we found. However, these are not all inclusive. They can be, whatever the doctor orders can be the intervention, but here are some of the suggested interventions. And one of the pieces that I'll go over is when a patient meets that severe sepsis criteria, the patient has met that severe sepsis and requires immediate intervention. The physician is notified, the patient is educated, and they're transported to the emergency department. Now, we all know that we have those patients that say, we are not going by ambulance. I'm not paying for that ambulance. I'm not going. It doesn't matter if they're having, an acute heart attack. They're not going by ambulance. So we have not put in there that they need to be transported by ambulance. However, they do need to be transported. So if the caregiver will take them to the emergency department or however they can get there, they need to get there. That's why we have a report called to the receiving emergency department. That is key. And that is a very big piece to the puzzle. If the nurse doing this assessment does not call the emergency department to provide report regarding the sepsis criteria of that patient, I can tell you exactly what's going to happen. I spent many, many years in the emergency department. The patient's going to present to the emergency department and say, my home care nurse sent me in here for an evaluation because I have a fever. And you know what the emergency department's going to do? They're going to say, okay, take a seat in the waiting room, which is not what our goal is here. So it's very important that that nurse provide that, that report off to the emergency department if they are not reporting off to EMS. Another one of the interventions that we had also encountered is we found that a lot of the primary care providers were very willing and actively involved with the sepsis, and that they wanted to start initiating treatment for patients prior to meeting severe sepsis criteria. So we have also had providers initiate antibiotics, but it is very important that if a provider initiates antibiotic treatment, that a skilled nursing visit be completed within 24 hours of the initiation of those antibiotics. It's one, we need to make sure that those that infection is susceptible to the antibiotic that they have been administered. So it's very, very important for that follow-up. We don't want to just say they've been treated with antibiotics, so they're all set and we'll resume our routine visit frequency. Next slide. We also put together an algorithm because every good nurse loves a good algorithm, so it's easy to follow. And here it basically walks all the clinicians through the sepsis screening tool. What we have done at our agency is we have laminated both the sepsis screen tool and the algorithm on a front to back, and they get to keep it right in their bags. So it's easy for them to walk through with. Next slide. And there's the follow-up, and the next slide is the intervention. Okay. This is the patient education zone tool. The early signs and symptoms zone sheet is designed to educate patients of the signs and symptoms of sepsis. You know, we know that most people, if we were to ask them the signs and symptoms of a heart attack or the signs and symptoms of a stroke, they would be able to give us some of those signs and symptoms. However, most people have either never heard of sepsis or they certainly can't give us the signs and symptoms. I can tell you when we first started, I sat down at a round table with probably about 15 very seasoned clinicians, and we all could not seem to put together all of the criteria for sepsis. So it's very important that we start to educate people on exactly what those signs and symptoms of sepsis is. So the zone tool provides a person with the information of the signs and symptoms of sepsis and what to do if they develop the signs and symptoms. That's really easily understood. It's intended to be left in the patient's home as a reference for not only the patient, but we utilize this with our home health aides as well. So our home health aides are able to review this zone tool with the patients when they are there, because we all know that the home health aides see the patients more than the nurses do. So they are able to say and walk through with the patient if they are having any of the symptoms that are in the green or if they're having any symptoms in the red. If they have any in the red, then they are to immediately contact the nurse, and we immediately schedule a nursing visit. So that follow-up is key. And they are not providing any type of assessment. This is all directed from the patient. So that has been very helpful with some of the home health aides as well as the patients, that the sepsis zone tool. Next slide. This is the sepsis protocol. The sepsis protocol was developed for agencies to adopt as their policy and protocol, ensuring that the sepsis screen tool is utilized as it was designed and provide guidance for the use of the tool. So, of course, we always have to have policy and protocol in place. So we have basically written your policy and protocol. You would just add your organization's name at the top with this. So that's also a very helpful piece. Next slide. And here's each pages of the protocol. Some of the key points about this, some of the key points about some of the screening tool is, and we came up with these from our beta testing, is that it is very important to do this screen tool at every visit. If you do this at Sock, Rock, and Research, then we are not going to catch, and we will be missing multiple opportunities of identification of sepsis. So it's really important that we do this at every visit. The interventions are recommended interventions. They're not substitutes for treatment or consultation or any direction from a physician. If clinicians choose to order, if the provider does an order for the blood work that I had mentioned, it's important that the nurse follow the agency protocol as far as taking orders and following through. It is not meant, the sepsis screen tool is not meant to be standard orders. And that education piece is very big. It's really important to educate them as to why things are being, why the screening tool is being done and what can possibly happen. Next slide. So here are some of our real case studies that we have taken throughout. So this scenario is a 49-year-old female admitted for nursing care for a diabetic foot infection. She is receiving IV antibiotics via PICC line. She's seen 3 times a week for dressing changes to her foot, assessment of her wound, and assessment and maintenance of the PICC line. The patient's wound has progressively been healing with improvement in appearance and decrease in the size of the wound. Her vital signs are a temp of 98.4, pulse is 72, respirations are 18, and the blood pressure is 116/70. She's alert, oriented ×3, breathing easy, denies any pain. She's pink, warm, and dry, and denies any complaints of bowel or bladder dysfunction. So if we were to answer the screening tool for question 1, yes, the patient has an active infection because of the wound infection, and the patient also has a source site of infection for the potential infection of the PICC line. Question 2 is no, she has no systemic criteria because her vital signs are all within range. And question 3 is no, because she has no new onset of organ dysfunction. So this patient was educated on the signs and symptoms of sepsis, and the screen tool was completed. Next slide. Scenario number 2 is a 91-year-old female admitted with COPD, a history of frequent pneumonia with possible aspiration and confusion related to dementia. The patient has a history of urinary incontinence. The patient has a supportive daughter in the home, who is her primary caregiver. Upon assessment, the nurse determines that the patient has a temp of 96.6, a pulse of 110, respirations are at 26, and a blood pressure of 101/60. The patient is holding her stomach and stating her stomach hurts. The daughter reports that her mother has had more confusion over the last day and that her urine seems to have a strong odor to it when she is caring for her. So under the screening tool, the question number 1 would be yes, the patient has a potential source site of infection with incontinence and a history of potential aspiration pneumonia. Question number 2 is yes, the patient has 2 systemic criteria. And then question number 3 is yes, the patient has signs and symptoms of a new onset of organ dysfunction because she has that new onset of abdominal pain. She's holding her stomach. So this patient meets all of the severe sepsis criteria. So this patient needs immediate treatment. The physician was notified, and the patient was transported to the emergency department, and a report was called to the receiving emergency department. And anybody, please stop me if anybody has any questions as I continue to go through. Next slide. Scenario number 3 is a 65-year-old male admitted for diabetic teaching due to being new on insulin, has a history of pneumonia and coronary artery disease. The patient has a supportive wife in the home. Upon assessment, the nurse finds a reddened area to the lower right leg. The patient's temperature is 99.6, pulse of 100, respirations of 22, SpO2 is 98%, and the blood pressure is 120/68. The patient has no complaints of pain, GI or GU dysfunction. So the screening indicates that on question 1 would be yes, the patient has a potential source site of infection with a reddened area to the lower right leg, because that could potentially be a cellulitis. Question 2 is yes, the patient has 2 systemic criteria. And question 3 is no, the patient has no signs and symptoms of a new onset of organ dysfunction. So this patient met the sepsis criteria. The physician was notified and antibiotics was initiated, and the nurse followed up within 24 hours of the initiation of antibiotics for this patient. And this patient we were successful at keeping out of the hospital. The next slide. Scenario number 4. An 88-year-old female admitted with a new onset of congestive heart failure. The patient has a baseline mentation of being alert and oriented. The nurse has been completing CHF teaching with the patient over the last few visits, and the patient has been completing all of the follow-up the nurse has instructed her to do, such as daily weight monitoring. At today's visit, the nurse's assessment is a temperature of 98.6, a pulse of 76, respirations are at 18, the SpO2 is 98%, and the blood pressure is 134/78. Bilateral lung sounds are clear, does not appear to be in any type of discomfort. When the nurse asks the patient if she has any pain, she appears to be confused and is unable to answer the question. As the nurse continues with her assessment, the nurse notes that the patient has a new onset of confusion with no facial droop or unilateral weakness. So, for this scenario, question number 1 would be no, the patient has no noted infection or potential source site of infection. Question 2 is no patient has no systemic criteria. And question 3 is yes, the patient has signs and symptoms of a new onset of organ dysfunction. Because the patient has a new onset of confusion is that question number 3. Now, this scenario is a little different. But what it does is, with the sepsis screening tool, is it keeps the clinicians focused. And it gives them clear direction. So 1, this may not be a sepsis case. Question number 1 currently is no. However, we don't know if there's an underlying infection that we just don't know about yet. And sometimes the providers need to go looking for it. And once they get to a provider or an emergency department, they will do multiple blood work, blood cultures. They'll run a lactic acid and things like that in order to see what's actually going on. So they may have to actually go looking for that infection. So it may or may not be. And question 2, at this point, the systemic criteria is not there. But we want to know why that patient has a new onset of confusion. So we need to find that out. So the physician was immediately notified. And the patient and the caregiver were notified as well and educated. The physician requested that that patient come into the office to be evaluated. So, and that's what was done. And it ended up being for this patient, it was Bell's palsy. So, next slide. Does anybody have any questions so far?
Any questions?
Oh, not yet.
No? Keep going, Amy.
Okay. All right. So some of the guidance for agency adoption is the implementation of the sepsis screening tool. It's really important that you make sure that everybody has a good understanding of why sepsis is so important. The buy-in is really important to that, including all of the procedures to ensure the completion of the screen tool by every RN assessment. We also have all of our clinicians do it. We have physical therapists do it. We have OT do it. And we also have the LPNs, and we also have the PTAs do it. And this is how we do that. Just one, the physical therapist and the occupational therapist, they all take vital signs. So we have educated and trained them on the tool. And if they have anything that they need as far as outside of the range or identifications, they immediately call in to one of the nurses. The same thing goes for the LPNs. In New York State, LPNs they fall under the registered nurse. They are not allowed to assess. It is outside of their scope of practice. But what they can do is obtain data. So they obtain the clinical data, such as the vital signs and the history. And then if they fall outside of the parameter, or if they're slotting yes to any of question 1 or 3, then they immediately call into the registered nurse who interprets the data and then follows up with the physician. So we are actively doing multiple screenings. So there are some days that a patient may have 3 screenings done in one day, depending on, what staff is actually out there. Following the timeline for the guidance of training and implementation is really important. As we all know, we have a ton of regulatory requirements, but we really need to stay focused with it. So one of the pieces that our partners have helped us with is at iPro is designing what we feel is actually an achievable timeline for implementing the sepsis screening. Next slide. Yep. A toolkit has been developed, and you'll receive, if you decide to start participating with the sepsis screening, the toolkit will be provided for you. And what's nice about this is that we really have we're actually giving you like a package all tied up with a nice neat bow and giving it to you. So if you go to the next slide, oh, maybe not. There in the toolkit has a list of all sorts of, it has the sepsis screening tool, it has the algorithm, it has the protocol, it has multiple education pieces, it has the sepsis 911 videos. So there's just multiple resources within that toolkit for implementation and education of the staff. Next slide. Al?
Okay, so I'll start off this collaboration discussion. And Amy, thank you for the thorough coverage of all that, the tool and all of the elements of the guidance. One thing that I would point out is that as an association, what we do is we schedule periodic and offer periodic statewide calls or webinars with the providers that are using the tools to, kind of have an information sharing opportunity and, take Q&As. And otherwise, when we are receiving, Q&As, we put them together, and again, periodically, we'll put something out that helps address that information to the agencies. So it's a constant, exchange of information and reinforcement on making all this happen, and we learn new things, all along the way. So collaboration across the clinical continuum is really critical for an effective response. And for example, one of the there are routine examples of where and how gaps in the system between partners really have a very serious potential. One case, for example, that was shared with me is where an agency that was using the tool, the RN, found the criteria to be positive, contacted EMS. EMS came and basically chastised us for wanting to refer this patient to the ER for sepsis because whoever was attending the patient really was reading the symptoms differently. Well, the nurse persisted. The patient was admitted, and that patient spent a month in the hospital being treated for sepsis. So that is very likely a patient that could have died in the circumstance where they weren't following the criteria that they had, and where things were sort of left to their own devices. We've been working very closely with EMS and the other sector partners to try to create the synchronization on the exchange of information, on the fact that in home care, the agencies are using criteria which are the established criteria for sepsis, which are the same criteria that the hospitals are to be using. And really, in fact, in New York State, most EMS providers, while they're not mandated, utilize a collaborative protocol in sepsis that pretty much mirrors the same criteria that we use. So collaboration is really critical. The fact that we have this tool available as a standard tool that agencies use is also very significant in that process. So that way, whether you're a provider in New York City, in Buffalo, or in any of the rural regions of our state, the other sectors and the representatives for those sectors know that the agency is using a standard tool and is using, again, criteria that is standard with what the hospitals are using. And that's really important for buy-in. So back in the spring, Amy and I did a similar webinar to this for all the hospitals in the state, and it was hosted by our State Hospital Association. And their point of emphasis to the hospitals was, you should be encouraging all your home care agencies to utilize a standard tool like this, so that way the information you're getting in ER and otherwise is standard. The other thing is that well, let's go to the next slide. So these are some of the gaps that have been found, again, in collaborative work that have been found and discussed with us. So one is both on report to ER and in consultation with the MD. Amy had mentioned earlier the fact that if the report to ER is not really made correctly or not made in line with the information on the tool, it's not likely to get the kind of timely response that's necessary, and the same thing in the physician's office. So that's a gap that certainly is very critical, and where we continue to work at all levels for collaboration and for knowledge on the part of other partners that home care is using this tool. On October 3rd, we're having a statewide sepsis summit. You're all welcome to attend. Gene, if I haven't sent you the agenda for it, again, you're welcome to attend this. But we are having a summit that brings together all the various partners and providers from every sector to talk about not only what each sector is doing in sepsis, but how this can be better knit together, both in a preventive way, early intervention, and then, of course, in post-sepsis care. Health information exchange is also really critical upon referral between the agency and EMS. But also there's the issue on the far end, discharge information to hospitals and home health. We've had agencies concerned often that patients are being discharged to home care, and there's no evidence that patient in the discharge summary that patient was treated for sepsis in the hospital. It instead may indicate an underlying condition, UTI or pneumonia. But it doesn't indicate the fact that patient was treated for sepsis, which, again, going back to the high readmission rate and higher risk of recurrence on a discharge, it's very important that information flows. So that's an area that we are further focusing on. Another, it relates to clinical pathways and interdisciplinary care for the post-sepsis dischargees, and the fact that we feel that we need to work more closely and more collaboratively, and to stimulate that in terms of the post-discharge care of sepsis patients, because the needs are so substantial. And again, you saw that in the video. That's an important next step for us. Mutual education and awareness of the tools across sectors. So home care needs to know critically about what EMS is using in their sepsis criteria, and to make sure that syncs with what they're using. And again, the same thing in interaction with physician offices and with hospitals. Cross-sector clinician training, also very important. So when we've held the sessions that we've held, we've invited to them clinicians from all the other sectors, so that way they're fully knowledgeable about the tool that we have, but also going to iPros training, where they've trained 10,000 clinicians. The training of clinicians to an effective level on sepsis is really important, and is really evidence of the fact that so much of sepsis is missed early on, where criteria are either misinterpreted or overlooked, and many of those are the patients that experience the morbidity, and unfortunately that die from sepsis because those symptoms are missed. And that's even in the testimony of physicians who their own family members have been septic, and the physician themselves have not accurately or not timely identified those symptoms, and it's only later on, when the patient's going into respiratory failure or other organ failure, that it was recognized that the patient was septic. So I mean, we could fill this call with case examples that we've been given from that. And then finally, again, what we're trying to promote is a continuum model in relation to sepsis. So we're also trying to align hospitals, home care agencies, physicians in commonality to work together in models, whether they're in a bundled payment or in a value-based model or in other models and approaches for a timely intervention of sepsis. And Amy's going to tell you of what she's doing specifically in her hospital system.
So here, some of the collaboration we've done at Mohawk Valley Health System is that we have had the hospital staff come to our sepsis, home care sepsis screening tool training. So we had the quality people come from the hospital, and many of the group that sits on the hospital sepsis committee came to our sepsis screening training, as well as we invited the vice president of the medical group. He attended our training, which was very helpful because he brought that information back to the medical group, so that they are more versed with what we are doing. And so when they are receiving phone calls from the clinicians out in the field, they recognize what they are saying. I sit and represent home care services on the hospital sepsis committee meeting. So it's very helpful to have all of the sectors sit on that committee meeting, so that we all know and can learn and communicate what each other is doing, so that we're all on the same page, basically. That communication is just such a key piece. And then some of the other pieces we have done is we've worked with our hospital case management team to collaborate with utilizing the same education materials. The Sepsis Zone tool is one of them for our patients who have been admitted with sepsis and they're being discharged out. Does anybody have any questions?
Amy and Al, this is Gina. I just wanted to mention, so I know you have quite a few slides left, and we're only scheduled to go to 12:15, and we still need to have some time to talk here and review some New Hampshire data. So I just wanted to be sure you were aware of our time, and I know your next section is on EHR, and I really want to cover that. So just wanted to let you know.
Sure.
Yeah, and you know what we can do? We can make that a priority because the style of the slides is very detailed and intense, which also just enables you to be, you know, to have something that you can have as a good reference beyond this. So what we can do is we can cover. Amy can walk through the EHR part, and if you want us to touch on anything beyond that, including next steps, we can. Otherwise, I can do like a 30-second summary, and then we can turn the rest to you. Does that work?
Okay. Yeah, that works, Al. Thank you.
Thank you.
Okay, next slide. Okay, so the EHR integration, of course, all the nurses, when they see paper now, they say, can we get it into the EHR? We don't want to go back to paper. However, some of the EHR vendors have been very, very helpful with collaborating with us. I don't know if anybody is on Home Care Home Base.
Yeah.
Is anybody on? Yep.
Yeah, we
okay.
have some.
Home Care Home Base. Home Care Home Base is very easy to get the screening tool in. We have had it built. I have the build, and I can easily send that to you so that it can be very easily put in. We have been working with the EHR vendors. Some of them have been very helpful with it, so we will be more than happy to do that. To get that integrated into your EHR is definitely a positive for buy-in with the clinicians. However, I will tell you that we did do this on paper, and we do have some very, very large licensed agencies in New York State that are also doing this on paper. There is the bulk export of the REDCap sepsis data that is easily extractable out of an EHR. And it provides additional data to benefit our organizations with health population and health indicators for us as well. Delta is another agency, an organization that is working with integrating the sepsis screening tool. And then some of the organizations have used their risk tabs within their EHRs to put in the sepsis screening tool because it's a modifiable tab for them. So I don't know what the EHRs are that you utilize.
We have at least one on Epic.
Can time.
Okay.
Oh, Can Time.
Mhm.
And McKesson.
Brighttree.
What is it?
Brighttree.
Sure.
Brighttree.
That's smart.
Okay. NetSmart. Okay. So Epic's pretty user-friendly. I've worked with Epic on the acute side. So their home care piece is not as robust as some of the other EHRs, but they are very user-friendly. So that we would be happy to help with Epic.
We're
Do you like
getting
how I put that?
Yeah, we like that. Okay.
You like how I put that? I know all about it. Yep. As I said, Home Care Home Base is probably our easiest, and anybody can reach out to me, and I'll be happy to send you the build for Home Care Home Base. McKesson we had McKesson prior to Home Care Home Base. And McKesson generally has a lot of ability to modify. You can put in a lot of you can add a lot of texting in there as far as, so you could actually write it in. So there's a lot of ability to modify with McKesson, so we can certainly help with that. One of the key pieces, though, when integrating it into the EHRs is being very cautious that the screening tool does not get altered. Because it is evidence-based, we don't want to have any alteration to the algorithm of it. So that is an important piece, and we are more than willing to help you with your integration. So you just need to reach out to us, and we can certainly help and potentially get on calls with your EHR vendors. Does anybody have any other questions?
Does anybody have a question? Excuse me. Nope, not seeing any.
I would just say, with respect to
Okay.
McKesson, one of our agencies was awarded their own grant. A foundation that they applied to just for implementing our tool. And I know that the company they've been working with is McKesson. So if there's any lessons to be learned from that, we'd be glad to share that with you too.
That would be great.
Yep.
Okay, so just to bring that to conclusion, and thank you for the time and the opportunity. In our next steps, we have really had some very major engagement, by state and some national players. So our state office for aging, as an example, has had us present this webinar to all the local departments of aging and their broader aging network. He has activated them to work with home care agencies on their community outreach in relation to the tool. We just did a PSA together on this sepsis tool and what home care is doing, and on the importance of older New Yorkers being aware of sepsis, and just a lot more in that regard. We've done the same thing with managed care plans in our state health department, and again, I could give you a number of other examples. We're currently working with EMS to do the same thing. So in our next steps, it's a lot more of that type of engagement. We also were asked by our state legislature if we would write a bill that would support the effort that we're doing, not only in home care, but that would also support a continuum effort. And we did write that legislation, and I think it passed the state Senate. We've been having meetings with our assembly on it. It always takes a little bit more than a couple of months to get something like that done. But I think it's further evidence of the interest and the support level. CDC has asked us to do a call with their communications offices on the work that we're doing in collaboration with our Office for Aging and others, and as has the CMS Hospital Sepsis Affinity Group. They've asked us to present to all the hospitals in the federal partnership I think it's in October, November. So a lot of that kind of activity happening in the next steps, as well as the conference that I mentioned. So let me bring my comments to a close. You have the slides that'll give the other detail. And as Amy said, we're happy to help in any way at all with your efforts and your considerations.
Al, thank you so much, Al and Amy. That was really, really comprehensive. I have one question in regard to the data collection. I know that as part of the agreement that when an agency signs the user agreement to use the tool and the algorithm and the protocol, that they have to agree to collect data. So if the tool is not integrated into the EHR and an agency is using paper, how do they collect the data? I mean,
right now information is able to be uploaded into this data portal in a variety of ways, even if they're not fully integrated. We've basically taken the position that we don't want a barrier or a burden on any data collection or reporting to be an impediment to the agency actually using the tool. So in terms of any individual agency that sort of needs that kind of a buffer or flexibility, or if it's basically for the whole group of agencies, it's not a problem. We'll just figure out some way in which the agency can contribute to the sharing of their experiences. So I would discourage no agency. And what we're trying to to do with other states is if the association becomes our partner, then in the sepsis effort, then the individual members in that state can just work directly with their association. If the association isn't the partner or some other representative group, then individual agencies can work with us, and we're glad to authorize the tool on an individual basis too.
Okay, great. I think that's it. Does anybody have questions for Al or Amy? Thank you so much for taking the time to do this for us and explain it. It was really helpful to have this overview. I have one last question. Do you know what other states are beginning to use your tool?
Well, so we have an agreement with Pat for the Massachusetts Alliance. So we actually went and we did an in-person all-day training. So imagine this session here spread out over 5 or 6 hours with exercises and other kind of stuff. Washington State, actually I was in very extensive conversations with Doris just before she retired, but they are looking at the use of the tool. Illinois, folks in Michigan, Wisconsin, so I'm sure I'm missing some, but other states like that are looking at the use of the tool. Also, like in New Jersey, the New Jersey Hospital Association is interested in having its hospitals either directly use the tool or have the hospitals have their affiliates use the tool, and they're interested in an association partnership with HCA. And there's a new association for home care in New Jersey, and we were just sort of chatting about that in Washington a couple days ago to see whether we could be helpful in that way. So.
Okay, great. Thank you so much, Al. We appreciate it.
You're welcome. You're welcome.
Bye now.
Thank you. Bye-bye. Bye, Amy.
Bye-bye.